access. We did everything until Dr. Carr came. Thank goodness. Got us out of the pediatric emergency room and the neonatal intensive care unit, which y'all probably can appreciate. When I finished my vascular training in Houston, I got this card from someone, I don't remember when, but I found this card. And I thought, how appropriate for the Chiefs. That's kind of how you feel. You know, you're trying to get to that bone up there, and you just about have it. You know, it's just right there within reach of you. And if I had something else I'd rather be doing today, this would be it. This is quail hunting. For those who don't know, this is the English pointer, which is a good little female pointer that I have, or used to have. And it was one of those mornings when the fog was frozen on the trees, beautiful 30-degree weather, and she's pointing a single there on the side of a logging road. So truly one of my joys. So what we're going to do is I'm going to ask some questions. There's supposed to be a handout today. We don't have it, which maybe that's better. So we're going to divide you guys up into junior residents and senior residents, 1 through 3 and 4 through 6, and see if you can get a little audience response. So hopefully you won't fall asleep. So I have 3 patients here. I won't start with the junior residents. I want you to tell me what would be your diagnosis of these 2 patients, this one and this one. What do you think is going on with these patients with acute swelling of their lower extremities? Which one? What type? Very good. Okay, so this is Phlegmasia alba dolens. This is early parts of cerula dolens on this patient. What do you think is going on with this particular patient and this along the same line as the other 2? So this is venous gangrene, and I've seen 2 or 3 cases of this in my career. All of them had metastatic cancer when I saw the patients. So that's the 3 varieties you can see of phlegmasia and the results of that having that. Alba is also known as milk leg many years ago. It was one of the things seen in postpartum patients. It's kind of the lesser degree of illness so far as phlegmasia. Cerula is the worst. Most patients, about 50%, will go through alba before they go to cerula dolens. Not everybody does that. These patients are all my patients, and some of these were years ago. Both presented with just that problem. And when you see a patient with phlegmasia, you know that's an iliofemoral clot. Okay, you really don't. You can do an ultrasound and go through all that business, but they're going to need a procedure for the most part. Rarely can you treat one of these patients with anticoagulation alone, but sometimes you can, but you have to be very careful when you're doing that. So alba dolens, all the deep channels are occluded, but the collaterals are patent. So with cerula, everything's occluded. There's no collaterals, there's no deep system, there's nothing. Nothing is getting out of that leg. And if you wait long enough, they will become hemodynamically unstable. They can sequester 5-6 liters of fluid in their leg. They come in with hypotension, a hematocrit of 50s. You know that they've sequestered a huge amount of fluid in their leg when they come in. So these are emergent problems, not something to be dealt with the next day, in my opinion. If you have a patient that's not, the treatment right now, I think, is catheter-based, thrombolysis and thrombectomy. If a patient for some reason cannot undergo those procedures, maybe they're not candidates for some of the thrombolysis, then you can still do open thrombectomies. And I still remember one I did with Dr. Burns as a resident. Basically, open the femoral vein, you're trying to clean out everything you can with a Fogarty, but you can't get the collaterals out. So kind of the way you do that is when you have the femoral vein open, you wrap the foot with a S mark, and you start the foot and you wrap up, and what you're doing, you're trying to milk the clot out through your femoral vein incision. So you can do them open. I haven't seen it open in a long time, but it is there. I've never seen a patient die, but they can die. They can lose their legs. Post-phlebitic syndrome can be significant for these patients. It usually, by 5 years, about at least half of them have post-phlebitic syndrome symptoms, which we'll look at some patients in a minute that have that. Again, the gangrene, all the patients I've seen with gangrene had metastatic cancer. So the left side tends to be more common. And why would the left side be more common? Senior residents. Okay, May-Thurner, and I'm going to show you that in a little bit. Tends to occur on the left side, tends to occur more commonly in the female. Some patients have pulmonary embolus with these problems, and sometimes they can develop compartment syndrome. We don't put many filters in anymore, and depending on the problem, a lot of times you don't have to use filters. If you're doing an open thrombectomy, you better use a filter because it's going to be dirty and you got to be getting a lot of clot broken loose and potentially embolize. So next patient's a 44-year-old patient of mine she had May-Thurner's, had a stent put in left side. She came in the office with her stent probably being down for several weeks, swollen leg, and she had venous claudication. So junior residents, can you tell me what venous claudication would be? You can say no idea if you want to. How about the senior guys? Anybody know? Okay. Well, maybe you'll learn something today. So these patients, when they walk and when she would work outside, her leg would become very tight and swollen to the point she felt almost like the leg is going to explode. So she would have to sit down and kind of elevate her leg. It always means that they have iliofemoral occlusive disease. This is a much underestimated problem, and frankly, we don't ask patients enough about this, the ones that we see that have post-phlebitic legs. But it is a real problem, and some people will tell you that it's worse than arterial claudication. Number one, these are usually young patients, and she had a farm. So when she was out working on her farm, she'd have to quit working. This is she's 44, very active patient except for this problem. So I did a venogram on her, and basically you can see her stent here, and the stent's occluded. I couldn't get through it. I got a wire kind of behind the stent, but I couldn't get through the stent, so I felt like I could not relieve this problem. So you're trying to figure out what am I going to do with a 44-year-old with severe disabling venous claudication. So the first time I've ever done this operation is called a PAMA procedure. So we do a vasal view removal of her saphenous vein down to her knee on this side. She's occluded on the left. Swing the vein over. You don't have to reanastomose this. This is just a normal junction. Swing it over to the femoral vein subcutaneously and then create an AV fistula from the superficial femoral artery. So that's in fact what we did. This is, that's her left side. I'm sorry, that's the left side, this is right. The vein graft's going underneath, and then this is the fistula. The fistulas keep it open because this is low flow, small venous structure. And even with arterial FEMs, you worry about patients kinking their grafts when they sit in a straight back chair kind of thing. So she's had that now for 4 years. This is her last ultrasound. She's got about 1,000 cc's a minute going through her fistula. My intention was to ligate the fistula, but I'm chicken to do it because I'm afraid if I ligate the fistula, she'll close off her bypass graft. And then she's going to be disabled again. So I've left it. She's got some pubic varicosity, as you can see, but she's not symptomatic from those. So I'm just following her right now. But she's got some swelling, wears her hose, but she's very functional. Does a lot of physical labor still. She's from over in Winchester. So this guy shows up in my office about 4 years ago with some venous ulcerations. Dr. Valier actually has removed some basal cell carcinoma. He's had this since birth. And I'm looking for a diagnosis, and I'll start with the senior residents because I'll be surprised if you get this. The only one I've ever seen. Anybody have any ideas? The leg is enlarged compared to the right one. It's hypertrophied. He's got port wine stains, venous malformations, varicosities of his leg. He's been good. He wears his compression hose. You're close. It's Klippel-Trenaunay syndrome. if this is your name, don't put it on some syndrome, okay? This is not easy to say. So he has everything. He has the capillary malformations, the venous the capillary port wine stuff, the venous malformations, and their bone and soft tissue in their leg is enlarged compared to the other one. And there's really not a lot you can do with these patients. They can develop cellulitis and sepsis. If they had necrotizing fasciitis, I would hope not to be on call. I could not imagine filleting that leg open and trying to remove the infection. Sometimes they can develop large venous malformations in their pelvis, can be more problematic. So the treatment basically is non-surgical. If you're considering this should be greater saphenous vein ablation, you don't want to do that until you're sure that they don't have, they can have atresia of their deep system. So you don't want to be ablating their only venous outflow. So you have to be very careful with these patients. And frankly, I have not done anything with this patient except just compression hose. Okay, so we're going to talk about this problem. And for the junior residents, what is this? What would you refer to this as? Very good. What causes venous stasis ulcer? Just a general idea. Okay. Well, basically, it's venous hypertension, right? So typically they've had previous DVT, not always, but usually. And we think of this coming from 4 systems, really 3 systems. But when Dr. Burns and I were seeing these patients 20 years ago, we thought we had nothing to offer them except compression hose. Clements even decided he wasn't going to see anymore, so he and we started seeing more of them. I said, what is this? I don't want to see all these venous stasis. Well, Clements decided he wasn't going to see anymore. I said, that ain't going to happen. That ain't going to happen. So anyway, we didn't know what else to do with them. Compress them, dressings, the nurses didn't like seeing them. Now we can do something for it because we realize that most of their trouble is not deep venous insufficiency or chronic DVT. Most of them have these other things that we can treat. So if you've got superficial incompetence of the greater or small saphenous, 75% have perforator incompetence. We can ablate those problems so that we can relieve some of that pressure off of the subQ tissue. And then the latest thing is a lot of them have occlusive venous disease of the iliac. And it's somewhat subtle, and the duplex has got a 20% false negative rate. So we're going to treat these problems. We can ablate these incompetent veins. If they don't heal, even if they have a normal ultrasound, I'm still going to do either a CT venogram or I'm going to do a venogram on the patient if they're not healing. So if we can correct these problems, we know that we can cut their healing time in half so they're not there for the next year getting their legs wrapped. And we can cut their ulcer recurrence in half as well. So we have something to offer these patients. Most of them are pretty miserable. They can't work. I've had several patients I've had to sign papers for disability because of these venous stasis ulcers. So their quality of life really is not good. You do have to be sure they don't have arterial disease. Sometimes they have both. Anybody take a guess of what number of an ABI that you would not compress, put a compression hose on? A number. 0 point, what do you think? It's close. 0.7, 0.8, you don't compress them because if you compress them, you're going to exacerbate the arterial disease. So you have to be careful that you don't miss that problem. Okay. So some words you need to know, students and everybody else. The gator area, that's the area that you see the deposits, the staining of the skin. The hemosiderin deposits, that's a staining of the skin from the red blood cell degradation. And the lipodermatosclerosis, which is a mouthful, is the thickening, hardening of the skin, the loss of subcutaneous tissue. And then the venous eczema we call stasis dermatitis. A lot of the primary care doctors think they've got cellulitis and they don't. They can develop cellulitis, so you got to make sure you know the difference. But most of them don't need antibiotics. They use steroid creams instead of antibiotics if they've got the dermatitis. this is just venous pressures. I don't want to belabor the point. I've got a bunch of other stuff to show you. But a normal person, if you walk, when you walk, your muscle pumps the blood out of your leg, your pressure falls, and then it resumes up here when you stop walking. If you've got all this disease and you start off higher than everybody else and then you dip only a little bit, then you're right back up. Just proving that this venous pressure is the problem. And again, we're looking at the saphenous, the small saphenous, and the perforators. Perforators go from like the saphenous to the deep system. Which direction should the blood go? From the deep to superficial or superficial to deep? Students, you know? And a normal perforator. You got a 50-50 chance. Superficial to deep, perfect. Okay, so you want to go that way. So if they become incompetent, the blood begins to go reverse back into the saphenous, and this creates more of that hypertension problem. So when these get over 3.5 millimeters in size and they've got more than a half-second reflux, and they're called abnormal, the bad boys always occur right at the ulcer, so we now presently do radiofrequency ablation of that perforator, so we're stopping that reverse flow. So that's how we find these. That's how we treat them. There's a number of perforators, but you're looking for the pathological ones when you treat the patients. This is May Thurner. It's kind of it's always been odd to me that the right iliac artery would occlude or stenose the left iliac vein. But that's what happens right here. And this is more common in females. We see more and more of this. A lot of it's subtle. A lot of people don't pick up on it. You got a 30-year-old who's having some mild leg swelling, maybe it's worse at the end of the day and they don't pay much attention to it. A lot of times they've got this problem. So that's May Thurner. This is an ultrasound. This is iliac artery. This is the iliac vein. You can see obvious compression of the iliac vein by the ultrasound. And usually we can determine this by duplex. So what do you think is going on with this patient? Get the senior guys. This is sort of a mixed bag. What do you think? Pardon? Okay. She definitely got venous stasis. She got secondary lymphedema of her foot, so she's got both. Most people with venous disease have a normal foot. They don't have swelling of the foot. So the calf swells, ankle small, foot looks normal. So she's got secondary lymphedema. I thought I'd just point this out, this small tip about looking at people with lymphedema. Lymphedema always starts distal and works its way proximal. So the foot becomes swollen. You can see these accentuated creases at the toes. And I'll show you what's called the Stemmer sign. So you'll see the squaring of the toes, the buffalo hump on the foot. And then the interdigital spaces, they say, are tight. I don't really look at that so much as just seeing this accentuated crease at the toe. And there's a name for this. I couldn't find it. So she's got both. Tough patient. So we always refer to these patients as having a Coke bottle leg. Coke bottle leg. That means the big calf, small ankle. So a lot of the younger people don't know Coke bottle legs. That's what we refer to these patients. Dr. Fisher, I had that slide up here, I don't know where it is. He uses champagne bottle usually. So his are champagne bottle legs, mine are Coke bottle legs. Same idea. Okay, this patient comes in Park Ridge a couple of years or so ago with a painful, tender right breast swelling over the last 24 hours. Right arm is swollen, and she had had a radiological procedure from her left arm 2 days earlier. It's 6 o'clock at night, and guess who they called to take care of the problem? It ain't radiology. It's us. So I go to see her, and this is her chest. So she's had multiple portacasts. You can see down here, one of the trauma guys have been working on her, I guess. She's got incisions all over her abdomen. She's got a G-tube. I don't know all of her history except this problem, and you can look at her chest and you kind of figure out what's going on with her. So do a venogram on her, and they have placed a stent into her nominate vein, and they have gelled her right subclavian vein. So there's no outflow to her right side. When you see breast swelling, it is a sign that they've got a big-time occlusion of their subclavian, a nominate, or something, because that means there's no collaterals getting back. The worst thing we see are dialysis patients. To me, if you see a dialysis patient with an arm and a breast swollen, a lot of times you'll have a big problem trying to fix that issue for them. Sometimes you can't. But to me, when I see breast swelling, I know that there's really a severe occlusive problem with her. Now, what I did with her is I just put in kissing stents in her. So she's got one from both sides. She's like 30-something. She's going to be back over and over and over. She has no venous access. Left her portacath in up here because she's going to need it. Again, I don't know all of her history, but she's in and out of the hospital all the time. So this is a patient I saw a little while. This is the first time I've made this diagnosis. I'm going to show you some first-time cases. She's a physician's wife, and he brought her to me and said, you know, can you do something for her? She kind of had a tentative diagnosis of lymphedema. Do you think she's got lymphedema? No way, her foot's normal, her calf's normal. She got all this stuff up here. She's got to the point where she can't walk very far. They want to travel and see the world, but she can't walk. She tried dieting, exercising, nothing has helped. Anybody have a diagnosis? We see it more than you know. I've seen it more than I know, but I've never tagged anybody with a diagnosis. And it's not a surgical problem either, really. It's got lipedema, whatever you want to call it. It's a common disorder, a fat disorder. It occurs mostly in women. I don't know what the deal is. Supposedly 17 million women have it. You're not going to see it as a general surgeon, but you're going to see it in your patients. And you might just have a little increased knowledge about what's going on with them, but it can cause pain, tenderness, swelling, and hers was just pain on walking. And there's not a, hold on. She, she's been doing leg wrappings and all this stuff, so I sent her to plastics for a liposuction. I think that's the appropriate management. So anyway, you've got a new diagnosis for a new problem, an old problem. You'll impress somebody by knowing the thing. This is my favorite tattoo. The fact that you want to put bitch on your fingers, but you misspell it, it just makes it better. This is my patient. Anyway, that's my favorite tattoo. So I'm sure the Tron boys have a lot better. So this is the lady I saw at Memorial. They called because of head swelling, shortness of breath, and she looks like this. Ah, dang, just ruined it. So what do you think's going on with her? I've got another picture would help. So what do you think's going on? She has thalassemia. She gets 2 units of blood per month for the last 5 years. She's had 6 portacaths, and now she shows up, she has this problem. Junior guys, you know what this is, right? SVC syndrome, due to multiple catheter placements. So she's got all the symptoms. She's in her 30s. Seems like all these miserable patients are in their 30s. She's very anxious. She can't lay down. She can't bend over. She feels short of breath. She can't eat. Very anxious young woman. And she's got all the symptoms of severe vena cava syndrome. She's never had this before. So this is her chest. That's what I want to show too. If you can see the dilated venous structures of her neck. She's got bandages where she had all these portacaths placed in the past. So most of the time, used to when you saw severe vena cava syndrome, you thought malignancy. But nowadays, to me, this is where we're going to see them right down here. These are the worst, the dialysis fistula. They've had 10 perm casts, and they've scarred up their mediastinum, and now they've got severe vena cava syndrome, which is why they want us to get perm casts out of patients. If y'all know, I'm sure you know that. There's a huge push from the nephrologists that we get those out and put the fistulas in the patient. The portacasts, you know, you saw the lady before a problem, and then this lady's got it. It almost seems to me you'd be better off putting a AV fistula in their arm and just use that for an IV rather than ruin their mediastinal veins, but that happens. We had a patient a couple of weeks ago show up with severe vena cava type symptoms. He's got metastatic prostate cancer, mediastinal adenopathy, clot in his right subclavian. The arm's not that swollen. He's on anticoagulation. The treatment of choice is going to be just treat his tumor. so he needs radiation chemo. You wouldn't want to put a stent in a patient with a big tumor, and then the tumor shrinks away, and all of a sudden the stent's, who knows what, happening to it. So it still is some malignancy related, but a lot of it nowadays is catheter related. So we do a venogram on her. I've got this UF catheter coming from her left arm here, and we've injected contrast. So what is this structure? Senior guys, people. This? Nope. Nope. It's azygos vein. And the azygos blood flow is going this direction. The stenosis is right here, and it's tight. It's really tight. I've got a wire coming up from below. So I've dilated a little bit. Now there's some blood flow coming into her right heart. Here's her problem, and this has been just ballooned. And then we put a stent in. This is a balloon-mounted stent. It's a 10 millimeter. We could jack it up to 12. And then we pulled her portacath back down through the stent because she's got to have the portacath to get her blood. So one of the things, the question I was going to ask you, is there any way of classifying superior vena cava syndrome? And there is. It's radiological. But if you have a significant stenosis but you still have prograde flow, that's a 1. Classification 2 is near complete obstruction, but but you've got antegrade flow through the azygos, and then she's a 3. She had retrograde flow through azygos. If you have a 4, there's nothing open, and so these patients have huge swelling of their head, and they have trouble breathing and airway problems and cerebral problems. And those patients, each classification correlates with degree of clinical severity. So the worst ones at the bottom, you do median sternotomies and trying to do bypass of their superior vena cava if you had something like that. So this is her after. You notice she's lying down. She has no JVD. This happened within a couple of days. This is a very satisfying case. And this is before and after. You know, 2 centimeter stent in the right place. She's subsequently been back many times. She's had to have the stent redilated, and various people have been working on her. Now she's got, what is it, hemosiderosis when multiple transfusions in your liver disease, is that right? Anybody know that? Multiple transfusions, liver disease? No? I think it's hemosiderosis. Anyway, she's having trouble with that. So I saw this lady. I was going to say this is Dr. Moore's former girlfriend. This is the lady I saw in you still have her? I'm glad to know that. Saw this lady in Edinburgh, Scotland. I walked up to her and said, why would you do all this? She said, honey, you really don't want to know. So you're probably right, I don't want to know. So now we have this patient, comes in the office. This third toe turned blue and painful about 2 weeks ago. So he's in the office. If you notice his foot, if you're looking for vascular disease, his nails look pretty normal, skin looks pretty normal. I don't see hair on his foot. He has pulses in his foot, pulse in the femoral artery you can feel. So what do you think's going on with this patient? Any of the junior residents have a diagnosis? Blue toe syndrome. And what is that secondary to? Very good. So this is blue toe. And for the students, this we may have talked about this, but this one of those things that looks pretty innocent but may not be innocent. So it is secondary to microembolization, cholesterol crystals, or small plaque. Usually, in my experience, it's been atherosclerotic irregular plaque in the aortoiliac system. It can be other things like this vasculitis in business. Sometimes aneurysm, although aneurysm embolization usually is larger, it'll be like a foot or a major embolic source. The treatment, if it's an aneurysm, obviously repair it. If it's atherosclerotic, if you can find a focal spot, you can stent, endarterectomy, or do something like that, and we've done that many times. I've got several octogenarians that when you do the angiogram, they got diffuse disease, so you don't know where it's coming from. I mean, from iliac to the popliteal, there's multiple plaque areas. And most of these I've treated with aspirin, Plavix, and statins. and most of them have done well, so some you treat medically. So it's one of those things that can appear fairly benign, but if you don't look at it, next thing could lose a foot, lose a leg, so you want to pay a lot of attention to it. The patient may discredit it's no big deal because their toe feels pretty normal now, and it's just this one toe. But don't be fooled by thinking that's a benign disorder. So what's going on with this patient, senior residence? Maybe this should be Jeopardy today. What do you think's going on with this patient? No idea? Okay, it's major bilateral lower extremity embolization. Something bad is going on upstairs on this patient. So I can't tell you what happened. This was like 10 years ago, but I did have something I want to talk to you about that I've seen a couple of times in my career. Again, I'm talking some unusual things, but this is major embolization. Major embolization. So something really bad's going on with his aorta, distal aorta, or somewhere in his aorta probably. So I'll talk to you a little bit about what's called shaggy aorta syndrome, and I've seen a couple of these. And it's so far as the diagnosis, radiological, when more than 75% of the length of the aorta from the arch to the mesenterics have disease, and it's got this 4 millimeter thickness by CTA. That make the diagnosis, the prognosis is really poor, the mortality and morbidity are very high, it's difficult to treat. You don't want to put a catheter or a wire in these patients' aorta, and it's relatively contraindicated to do an aneurysm endograft repair because of the risk of embolization. So this is sort of a textbook appearance of what that may look like. So you can see this patient's got an aneurysm down here. I think the subject of the paper was that you'd be very cautious about repairing an aneurysm in this type of patient. They tend to embolize their kidneys as well, so a lot of times they've got renal failure when they come in. There have been some reports where they will stent graft this piece, but you know that's fraught with problem. This is a post-mortem examination of one of these aortas, so you can sort of see what it looks like. And he's got an old graft, looks like below, or she has, that they'd had. So this patient shows up in the office with this problem. He had a CAB 2 weeks ago. So junior residents, what's going on with this patient? You really don't need a history, you just need to look at his hand and wrist. Very good. So they've done a radial artery line on a guy that probably has very poor ulnar flow, and he doesn't have an intact palmar arch. So sometimes you get called, I don't know if you put in arterial lines or not. We used to put them in all the time. And the question is, what do you do to assess a patient before you put an arterial line in? Anesthesia will tell you that they don't need to do anything. So what tests would we typically do to look at blood flow of the hand? To do an Allen test. And what's a negative Allen test? I won't belabor the point, but basically you're going to occlude both radial and ulnar, squeeze the fist, open the hand up, it's pale. You turn loose the ulnar artery first, and the hand should feel within about 5 to 7 seconds. That's a negative, meaning that they've got great ulnar flow, they've got palmar arches intact. So that's a negative study. If it's more than 15 seconds, then it's considered positive. The anesthesiologist will tell you that there's poor correlation between the Allen test and the end result of putting in an arterial line. Some of it's because I think they're too lazy to do it, tell you the truth. And if you read these studies, they'll tell you that if it's abnormal, if you can find another site, go somewhere else. So if you call you to the unit to see a patient who's got a ischemic looking hand, who's got an art line, you might want to think about that. Really, so use an alternative site if it's positive. And then if you can't do anything else, you can Doppler both vessels and kind of occlude them and just kind of prove there's some Doppler flow when you occlude the radial before you put the art line in. Or that you may be moving it somewhere else if they call you at night about that. This is an easy one. Patient with a femoral endarterectomy, bovine patch, prosthetic patch that came in with fever, pain, and this appearance. So What do you think's going on with this patient's students? Junior residents? Senior residents? Yeah, he's got an infected femoral artery, and now he's got septic emboli to his foot. So that patch we put on there, that Gore-Tex patch or whatever it is, has gotten infected, and then he's embolized his foot from the patch. So this is a source of femoral patch infection with embolization. Lady I saw on the 3rd floor last year or so forth, patient with severe lupus, end-stage lupus. They called us to evaluate her because of her hands and feet. She's somewhat moribund when I saw her. She's on steroids, immunosuppressants. When you see her, you could feel radial pulse, ulnar pulse, you can feel pedal pulses. So what do you think's going on with her? No. Ding, ding, ding. Okay, so she's got severe vasculitis, and there is nothing we can do for her. There is nothing we can do for her. So she was, I think, put on hospice or something. Those vasculitis syndromes are something that we see, but usually the only thing we can perform typically are amputations, and she's past that point, obviously, at this stage of her disease. All right, just going to answer a few questions. Let's see, I think I talked about everything. This was going to be your handout, which never got down here, which is probably good because it would just have clued you to what's going on. So does anybody know the oculostenotic reflex? This was coined by Spence Taylor. I love this. I just brought this up, I thought it was kind of neat. It's not, you won't find it on Google. This is what Dr. Taylor was referring to as our competitors, radiology and cardiologists. And that is, if you see a stenosis, you put a stent in it, regardless of its significance. So you see, you stent. Okay, that's all I have. I kind of went through this a little faster than I thought I would. So I'll try to answer any questions if you have questions about some of these topics.
Have questions for Dr. Greer? Mike, I wanted to ask you how some of those patients turned out, but that they were certainly interesting. And Dr. Greer's had a great career here as a clinician and as a teacher for the medical students. He coordinated the junior clerkship for 15 years and pretty much retired the trophy for Teacher of the Year from the medical students, not just here, but in Memphis as well. So we're very proud of his contribution to that. He's now emphasizing venous disease, and I'm really happy to see so many of these cases were venous, because we talk about arterial cases all the time.
Yep.
And they're what vascular surgeons, frankly, they're easier to do. As difficult as they are, those diseases are more easy to approach surgically, but the venous disease has been way underestimated over time. And I think that your emphasis on that, and he's now doing a lot more work with venous disease, and I look forward to more of those. Bob, you have something you want to?
Yeah, I didn't quite get what you did to that lady with the May-Turner syndrome where you created the fistula. Could you go back through that again?
Yeah.
That was fascinating cases, by the way.
Oh, thanks. These damn computers. Let's see. I guess go down to here. It's the first time I've ever, and matter of fact, it's a good thing to talk about since we've got a few minutes, because it's a way of bailing out. You're going to have some patients that you cannot reestablish blood flow back into they've got an occluded iliac, and you cannot get the blood flow back to the primary system. So what you're doing is this vein, this saphenous was taken out of this leg, vasoview down to the knee, take the vein out, you got a groin incision here. So you pull the vein up, and then you subcutaneous tunnel it to the left femoral vein. So you're just doing a bypass. The valves are going this direction. So the blood comes up out of this leg, out through the saphenous, into this femoral vein. And because the vein's like 3 or 4 millimeters, it's small, you worry about occlusion, you put the fistula in here. So the fistula will ensure more blood flow through this bypass graft and keep it open. And you can't use Gore-Tex if you're in a squeeze and you got to do something now. You can use Gore-Tex, but you need to add the fistula to it, at least to begin with. It will bail you out from someone who's losing their leg due to venous occlusion.
Your segmental graft there, Mike, is that a part of the distal saphenous? You did anastomosis there and there.
This is extra saphenous I had.
3 anastomoses for everybody. You've got 1 to the vein, and then you've got your 2 for your fistula. So that's a saphenous. That's a short segment saphenous graft to the saphenous.
That's right.
Vein. Yeah.
Short piece of saphenous, superficial femoral artery to the fistula.
Yeah.
It's like a vacuum effect or a negative.
Yeah, exactly. Exactly. It just sucks that blood up from their leg because you got all that arterial flow going through it. And hers.
What do you call that? How long has that been described? I hadn't seen that.
The Palma procedure's been around for a number of years, but I don't know the first one I've ever done. But you read the literature, people do talk about it. It is a bailout procedure. And for her, it's been great because she was basically disabled from the venous
She's the
claudication.
one that was like 44 years old. Yeah.
Had a farm, couldn't work, couldn't do her job.
What's the etiology of her May Turner? Did she have any problems? She had
a May Turner, had a stent.
DVT or any?
Yeah, she had DVT.
Femoral?
Yeah.
Okay.
Cleaned that out, put a stent in her. I think she occluded probably several weeks before she came to see me. If you come early and get them out, but if they wait too long and that organized clot, sometimes you can't get stents open.
Yeah, she already had the stent in.
Yeah.
Yeah. Heath?
Dr. Greer, that's fantastic, as usual.
Well, thank you.
Just a little more common question, something that anybody in here would see, especially if you do general surgery practice. So do an operation, patient post-op, leg swelling, you get an ultrasound, they've got a DVT. So what should be our initial approach, somebody who's not on anticoagulation, they've had, let's say, a lap chole, and they have leg swelling, and we get a report back that says they've got a DVT. What should be our next step for those patients?
Just anticoagulation, if you can anticoagulate them. If it's an iliofemoral and you can't anticoagulate them, you probably put a filter in the patient. So that's typical post-op. The ones that are unprovoked, who just coming off the street with a DVT, then you have to worry about other things like hypercoagulable states, cancer, things like that. But post-op patients, that's always one of my favorite oral exams for students, is I give them a post-op. I actually give them a Dr. Moore bloody, nasty, low anterior resection on a 300-pounder that has a swollen leg 2 days after, and say, what are you going to do about it? Going to order ultrasound. We're going to get it stat. We're going to find out there's a DVT. And what do you want to do? They want to give them heparin. I say, no, Dr. Moore said you can't give them heparin. It's iliofemoral, so what would you do? Yeah. Then finally, we're going to put a filter in the patient. If they develop phlegmasia, then you're going to have to go remove the clot without, you're going to be in a tight spot so far as anticoagulate. If you can't anticoagulate them and they got a kind of acute phlegmasia, you probably put a filter and try to remove the clot without anticoagulating.
So which ones need vascular referral? Just phlegmasias or?
Pretty much, yeah. Usually treat the other ones. A lot of people don't know what to do with DVTs. They don't want to deal with them long term. So if you're going to anticoagulate them, you're going to put them on, a 10A inhibitor, a thrombin inhibitor, and then what do? You're going to send them home and see them back in your clinic, and are you going to decide to take them off the Eliquis? Who's going to decide to take them off the Eliquis? So a lot of times they refer them to us to do their follow-up. And it's not very exciting kind of work, but then that's the next decision, is about taking them off. We do put the compression hose on sooner. I don't like getting them out of bed that day usually, but we put the compression hose, let them get up if you've anticoagulated a patient for a post-op DVT.
You mentioned at one point that we don't put in as many clips or
filters
anymore. Patients that have had pulmonary emboli, I don't have that many patients in the hospital anymore. That's a change. If you have DVT and pulmonary emboli, still do that or not?
If it's a DVT, a pulmonary emboli, and you can put them on heparin, then we don't usually put filters in those patients.
Okay.
If they've had a massive pulmonary embolus and it's iliofemoral, and if they can't tolerate another another emboli, then you probably filter those patients. But when you pull up IVC filter on Google, it's going to have mostly lawyers for the first 5 clips about suing people about filters. We do use filters, usually they're temporary, and we get them out within 6 months for the most part. If at 6 months you think they need a permanent filter, I'd take the temporary out and put a green fill in, which would be a permanent. But the studies have shown that you don't really improve their survival a lot by putting in filters, matter of fact, very little. And that filters over 6 months, if they're temporary, tend to have a high incidence of complications, namely perforation of the vena cava. So we don't use near as many filters. I don't know, but the trauma guys are using as many filters as they used to use. Probably don't. Yeah.
And why did you start using the same reason? Or data?
Well, they got a heck of a liability problem. They can't get them back to take their filters out.
That was part of it, but the literature was indeterminate on whether or not it improved survival by reducing pulmonary emboli, and the literature is.
That's a pretty
Showed that it-
substantial. That's a pretty substantial.
that it
thing
doesn't.
to me, over time. I mean,
So, we went from thinking we were improving survival on, incomplete data, and people kept looking at it and showed that it's not indicated, and had all these problems with the filters migrating and patients not coming back to have them retrieved, and was just turned out to be something that we didn't need to do anymore.
My filter patients, I've got a yellow legal pad on my desk, on my wall, taped to it, and it's got all the patients I put filters in. And that thing didn't come off till I've taken their filter out and scratched their name off. Otherwise, I can't keep up with them. And I don't want to be, found negligent in these patients. So it's.
that's a real step forward, though, that retrievable filter.
Oh, yeah.
Which
yeah.
occurred maybe 10, 15 years ago.
Yeah.
Because prior to that, it was a green field only.
They're all permanent back then.
Yeah.
And then they had the bird's nest, all these other ones, the trapeze, they all clotted the vena cavas. It was a mess.
Clotted the cava completely.
Yep.
I had a trauma patient that had a acetabular fracture, I think had an iliofemoral DVT, put a temporary filter in him, and he got lost to follow-up with me because he had all this orthopedic rehab and things that he did, and I actually sent him, you may remember, Mike, I sent this guy to you. He finally showed up like 2 years later. It had some vague abdominal pain. Somebody got a CAT scan on him, and the filter is partially eroded through the wall of his vena cava, and it looks like if he pulled it out, it could be a big problem. So he's hanging on to his filter.
Oh, I would think so.
I've removed one open, and it's a formidable thing to open a vena cava and take the filter out. You can do it. Actually, they're so enmeshed in the vena cava, you can actually just take wire cutters and cut all the crap that's outside the vena cava and leave the inside piece there. It's not going to embolize. They're all grown into the wall of the vena cava. So I'm sure Dr. Rowe could probably do it laparoscopic. I'm sure they've got laparoscopic wire cutters. Just clip all the pieces.
Send him to Mike.
Yes, sir.
Have you had an opportunity or seen a patient that's had SVC syndrome where you couldn't open them up and you had to refer them to a heart surgeon to do some kind of bypass, maybe from the right atrium down to the vena cava? I've never known of a patient who actually went through that process.
I know Rob Hedrick has done some of those, and I don't know that I've referred him a patient. I've got one right now I'm dealing with. I've dilated her, but she's borderline of going into renal failure, so I'm trying to putz around with her for a while until she winds up on dialysis, and I can be more aggressive with her. But she's 35. But no, Rob Hedrick has done those procedures. He's the only one I know of that's done the vena cava reconstructions of the mediastinum.
Dr. Miles.
Dr. Garrett, there were 2 questions on AppSite this year that I think a lot of us didn't expect, and I thought you could give us some ideas about these things. First of all, there was a picture of a lady with varicose veins, and it asked what would be the optimal treatment for that patient, I believe. If y'all will remind me, it didn't say the initial treatment. I think it maybe said definitive. Optimal cosmetic. And then the next question was a picture of a lady that I believe had spider veins, if everyone agrees. And again, what is the optimal treatment for that patient
Okay.
for a cosmetic outcome?
For spider veins, it's just sclerotherapy, so it's pretty simple. If you've got varicosities, now if it's, for us when we see varicose veins, they typically have to be symptomatic. itching, swelling, achings, yada, yada, yada stuff. So once you see and you examine the patient, you find the varicosities, then you need a duplex, and usually want to approve whether or not they have saphenous insufficiency, which would be the cause of their varicosities. And so the treatment would be ablation of the greater saphenous and then stab phlebectomies of the varicosities. So when you get into varicose vein stuff, you got to deal with insurance companies. If you've got private insurance, sometimes it is a bitch getting authorization to do them. But that radiofrequency or laser ablation with stab phlebectomy is how we manage most varicosities.
I think one other point, you made it on your slide, just to reemphasize, is with the phlegmasia albidolens in the acute situation. I have personally seen, and especially some of those patients with metastatic malignancy, they show up in the emergency room in shock, and you can't figure out why, because their leg is not swollen enough yet to reflect that sequestration of fluid there. And I've seen that, several times. And so the phlegmasia albidolens is something to think about in a patient that you can't otherwise understand why they're in shock.
They're both serious problems.
Yeah,
You don't need
really
to screw
are.
around with
Yeah.
those. You want to get
Yeah.
something done about
Exactly.
them quickly.
Yeah.
And that cerulite I showed you is not a very bad case. I mean, the whole leg can be tense, blue. They can be really impressive.
Dr. Barker?
Mike, that was really great. Is there any role any longer for that barbaric procedure of vein stripping, where we used to like pull the veins out and wrap them in an ace bandage? And
Yeah.
I always thought there's got to be a better way than this. Is there any role for that?
Rarely. And usually we let the intern pull the vein out, just tell them to rip.
Oh, yeah.
Pull the vein out, and they're always impressed with it. I'm not sure the students are up to the ripping the
Dr.
vein
Arnold's
out.
back there showing.
He would be
he's
doing it.
it himself,
The answer is rarely, rarely, rarely. If we do these ablations and they recur the second time, then sometimes we'll strip the vein, but I may have done one the last 3 or 4 years. Very rarely we strip them anymore. Yeah, you put the catheter in the saphenous. We usually ablate them from knee to saphofemoral junction. So you put the catheter up there, whether or not it's radio frequency or laser, it's basically burning the intima of the vein and just sealing it, causing really a thrombophlebitis. That's how you get rid of it. And then now there's Venasil, which is a medical glue. You can glue them from the ankle to the groin. It's a stuff that's been used with AVMs in the brain in the past. It's expensive. You cannot get a private patient authorized for Venasil. So that's a new thing, and it's much kinder. When you do the RF, you have to, what's called tumescence, you have to fill all the area around the saphenous has to be filled with fluid so you don't burn the sub-Q tissue. So that takes a while, and it's pretty uncomfortable. So you have to do the tumescence to get to do the RF.
And frequently, this does leave a patient with a palpable thickening, at least in the short run.
It can.
From that scar tissue, because I had
Yeah.
one of our employees actually had me look at her leg a week ago for that. And
Yep.
she's out a month or so from that ablation. If you think about physiologically the way it works, that's what
Right.
it does. It creates a scar of the vein.
There's
So-
about a 5% chance of DVT with those procedures.
Yeah.
If they come back in 4 days, we scan them. If there's any clot in the femoral, we'll put them on 2 to 4 weeks of Eliquis. But that's rare to happen. Some of the sclerotherapy, they can get staining of the skin, so now they're not happy because they've got this brown discoloration of where the vein was, but that's not common. But you do have to inform consent and tell patients that sometimes cosmetic results not as good as you hoped. But it's a common problem.
Dr. Greer, as everybody said, this is a great presentation.
Thank you.
Typical for you. Thank you very much.
All right, thanks.